right exams was like actually neurocysticercosis for like brain infections, where they show you multiple cystic lesions that have tiny calcifications in them. And I think there was also like a path slide showing you like a Scolex for like neurocysticercosis. The next time I give a lecture, if I see it which is going to be on like the 5th of February, like next in in a week or two, I'll try to put more right exam stuff in there just to help you out before your test. So I'll get started now. So these are so like there's lots of different things that can affect your brain in terms of like different CNS infections. What I'm going to try to do today is just go over the major ones that I think you might encounter like on a test or in clinical practice. I'm going to start off by going over different types of enhancement: leptomeningeal, pachymeningeal, and then like the differential for rim enhancement. I'll talk about how the evolution is for a brain abscess, starting from cerebritis to actually a mature abscess. I'll talk about viral encephalitides. Then I'll talk about different opportunistic infections you can get when you have HIV. I'll talk about CNS TB. And that's pretty much it. If I have slides at the end on neurocysticercosis and there's time, I'll go over that as well. So this is so just to start off with, Saisi, are you there?
Yes, I'm here.
Okay, so just a generic question. So so you have a young male with fever, headache, photophobia, nuchal rigidity. What would be the best first test to do, the most expeditious first test to do in like the ED in terms of like imaging?
I'm using CAT scan to rule out intracranial mass lesion before LP.
Perfect. Yeah, I mean, like the most sensitive test to look for a brain infection would be an MRI with contrast. But if you're trying to expedite getting an LP and starting the patient on antibiotics, the head CT is the best initial test to do, just to be practical about it. And contraindications, if you do an LP, are going to be evidence of increased intracranial pressure. Like if you see obstructive hydrocephalus, if you see diffuse effacement of sulci and cisterns and low-lying tonsils, if you see like a lesion with edema, that could be like an abscess that's causing midline shift and like impending herniation, those would be contraindications to doing a lumbar puncture. So Saisi, so this is so like same patient now. Let's say you've actually gotten a brain MRI in this patient. What do you see here?
There's a hypodense area, likely pachymeningeal enhancement.
So this is not.
Yes,
It's a brain MRI. There's two post contrast T1 weighted images here. So try again. Tell me where do you see the enhancement?
So right temporal area and quadrigeminal system also.
Right. So it's kind of within the sulci in the right frontotemporal region, the sylvian fissure, and it's also kind of along the margins of like the brainstem, like in like the cistern over here, anterior to like the midbrain. So how would you characterize that? Is it pachymeningeal or is it leptomeningeal?
So pachymeningeal.
It's not pachymeningeal.
Oh,
It's actually leptomeningeal. So leptomeningeal enhancement is like, you'll see that kind of in the same places that you'll see subarachnoid hemorrhage, within fissures, within sulci, and around the brainstem, and also along cranial nerves. Pachymeningeal is dural enhancement. That's going to be in the same places that you might see. It's where dura is. It's going to be in the same places where you might see a subdural collection along the brain convexity involved in the falx or maybe the tentorium. So if you look here again, enhancement in the depths of the sulci involving the fissures and in front of the brainstem, that's all leptomeningeal enhancement, not pachymeningeal.
Okay.
Okay. What other complication is present on here, Saisi?
Complication could be hearing loss.
On the image specifically, what other thing besides leptomeningeal enhancement is here? Look at the ventricles.
Hydrocephalus.
Yeah. Exactly. If you have, if you have meningitis or even subarachnoid hemorrhage and abnormal fluid, pus, or blood inside of the CSF, it's going to clog the arachnoid granulations, and you can get obstructive hydrocephalus from that. Okay. What's your differential for leptomeningeal enhancement? Do you only see it with infection, or do you see it with other processes?
Paraneoplastic disease. Leptomeningeal metastasis can cause that.
Yeah, you could see it with different infections like bacterial, granulomas like TB, even viral like meningitis can sometimes have enhancement too. Inflammatory things like sarcoid can also give you leptomeningeal enhancement, and then like you were saying, carcinomatosis is another big thing to think about as a cause for leptomeningeal enhancement. So infection is one broad category. Inflammatory things like sarcoid, and then finally sarcoid like neoplasms, specifically like leptomeningeal carcinomatosis can give you this appearance. Sturge-Weber is another thing that can give you leptomeningeal enhancement as well. That classically is going to give you unilateral leptomeningeal enhancement with cortical calcifications, brain atrophy, and a big choroid plexus on one side. I'm just going to go through this kind of quickly. I mean, you guys probably know this better than me. So the organisms that are associated with different with meningitis are going to be different depending on the age group. So obviously neonates, groupies, strep, and E. coli are kind of like normal flora in like the lower GI tract and like the vaginal vault. So those are the organisms that are going to be predominant in like neonates, older children, Neisseria, strep flu, and like less commonly H flu because of the vaccine. One thing that radiologists are taught is that like you can sometimes get sterile subdural effusions when you have meningitis, which was more common with H flu before the vaccine was as ubiquitous. And for adults, I mean, strep pneumonia is like the big one that people talk about. So commonly you can get this from hematogenous spread. You can also get this from local extension if you have sinusitis or mastoiditis. It's really an LP diagnosis and clinical diagnosis. You don't really need the MRI or CAT scan. Well, you would need the CAT scan maybe to like exclude like increased ICP before doing like an LP. The MRI, I think you wouldn't really need unless you're worried about a complication of meningitis like an abscess or cerebral venous thrombosis or an infarct. So what might you see on CAT scan in patients that have meningitis? Early on, it might be normal. If it progresses, you might see hydrocephalus like you're seeing over here. You might see effacement of sulci and cisterns from generalized brain edema. So anything that's densely cellular will be hyperdense on CT. So if you have pus within your subarachnoid space, it'll be bright on CT, kind of mimicking subarachnoid hemorrhage. And this is kind of like an anatomic correlate of that. So hyperdense material within the subarachnoid space. This is white cells and protein, and this is just a pathologic specimen showing the same thing. When you give these patients contrast, like you'll see enhancement that kind of follows that same pattern. So another patient that also has meningitis, if you compare sides, CSF should be pretty dark, typically 0 to 20 Hounsfield units. When you have abnormal material in the subarachnoid space, whether it's blood, pus, or abnormal cells, say from like carcinomatosis, it'll become dirty looking and be brighter on CT compared to normal simple fluid. So this is pus within the subarachnoid space in front of the frontal lobe. This is post-contrast showing enhancement where the pus is. Just another example, again, showing leptomeningeal enhancement. You'll see it along the fissure over here and going into the sulci. So for MRI is obviously a much more sensitive modality for looking for meningitis. The two best sequences, I think, for looking for meningitis are going to be FLAIR, and then T1 post is the most sensitive. Saisi is still there?
Yes, I'm here.
Okay. Can you give me a differential for things that are going to give you bright signal on FLAIR in the sulci and the fissures?
I think from infectious.
It's similar to like what we just talked about. It's similar to the differential for enhancement in the sulci and fissures, but there's one or two other entities, one or two other situations we can get bright signal as like an artifact. So infection can do it.
Yeah, inflammation like sarcoidosis also.
Right.
Leptomeningeal enhancement can cause that. Also, like some press feature can cause a similar picture, I think.
Okay.
But it's not in that area, mostly in the posterior, but can happen in that frontal area also,
right.
cortically based.
Right. Hemorrhage actually also. So subarachnoid hemorrhage, the two best MR sequences are going to be flare and then either grade nurse susceptibility. So infection can do it, inflammatory things can do it. Like you're saying, in some cases, I guess like if you have press, maybe you can have that, but that's less common. Subarachnoid hemorrhage, you can definitely see on flare. Do you know what situations that like if you give the patient something, if you administer something that can give you bright signal and flare in the sulci? There's two things that you can administer, like as a doctor, that can give bright signal on the sulci and flare.
Gadolinium. But
Okay. So actually, oxygens, supplemental oxygen and propofol are two things that that can artificially give bright signal and flare in the sulci. And this is just T1 post. So this is the most sensitive MR pulse sequence for looking for meningitis, T1 post with fat saturation. And again, differential for leptomeningeal enhancement, meningitis, a carcinomatosis, something inflammatory like sarcoid. Things like TB and sarcoid like to go to the basal cisterns classically. And then lastly, if you have unilateral leptomeningeal enhancement in a patient that has like seizures with atrophy, cortical calcifications, and a big choroid plexus, think of Sturge-Weber disease or syndrome. This is just an example of Sturge-Weber, just since we're talking about leptomeningeal enhancement. So this is a patient that has cortical calcifications, atrophy on one side, and they have all this diffuse leptomeningeal enhancement. I'm just going to skip through this because this is not an infection, but it's in the differential for leptomeningeal enhancement. Okay. Let me see who else is here so I can call on someone else. Peds Neurology is logged in as one person with 4 names. Theodora or Dave or whoever's on Peds Neurology. Can you guys hear me?
Yeah, we're all here.
Okay, cool. So take a look at this case, similar to the one that I showed to like SICE. Tell me the type of study, the planes, where the enhancement is, and give me like a differential for it.
So the first one on top looks like a axial T1 post contrast, and the one on the bottom is a coronal.
Perfect. Good.
It looks like there's enhancement of the dura. You see it like going along the falls.
Good.
So I'd say this is pachymeningeal enhancement.
Correct. Yeah, there's diffuse dural-based or pachymeningeal enhancement along the brain convecities, along the falx, and also along the tentorium, and within the posterior fossa dura here and here. So that is actually correct pachymeningeal enhancement. So, I mean, in this case, it's meningitis. Can you give me some other causes of pachymeningeal enhancement? It's similar to like leptomeningeal, but there's one other thing that can also give you like pachymeningeal enhancement.
So I know that metastases can also cause pachymeningeal enhancement, infection.
Okay. Can you give me some examples of like 1 or 2 metastases that'd like to go to the dura?
I think the prostate.
Yeah, exactly. When prostate goes intracranially, it likes to go to the dura much more than it goes to the brain parenchyma. Lymphoma can also go to like the can also involve the dura as well. Breast, just because it's so common, can also go to the dura. But like prostate, like you were saying, for much more commonly goes to the dura than it goes to the brain parenchyma. Infections, like we're talking about, that's a broad spectrum of infections can go to like the dura as well. Inflammatory things like sarcoid can also go to the dura as well. There's an entity called idiopathic pachymeningitis, which I think is IgG4 related, that can also go to the dura as well. And there's also some other weird inflammatory things like something called Erdheim-Chester that can also go to the dura as well. Let's say I did a lumbar puncture and I didn't tell the patient to lie flat afterwards. Can you tell me in that setting, and they had headaches, what would you think of if you saw a patient with that clinical scenario and dural enhancement?
So intracranial hypotension.
Perfect, good. Okay, so again, enhancement along the brain convexity and not going into the sulci, along the falx and along the tentorium. That's pachymeningeal enhancement. So we just talked about the differential, so infectious and granulomatous disease, neoplastic, and we talked about like considerations for that. So prostate and breast are big ones to think about. Meningiomas, and lymphoma. And then lastly, CSF leak is an important one to think about too. If you have a patient coming in after trauma or after, say, like an LP, and they have like persistent headaches that are positional. This is a really old picture of my daughter. She's 9 now. This is her like last year, still wanting to be a doctor, I guess. So Theodora, we kind of just already talked about this, but tell me what you see on here.
Sorry. So, first image is a coronal T1 post.
Yep.
Middle one is a sagittal. Is that also post? Yeah.
No, it's not. I mean, this one, like, I know this is post because I could see vessels enhancing and that kind of stuff. If this was a post, you'd see veins, you'd see like the pituitary, the infundibulum, and like and that kind of stuff enhancing, and you don't really see any of that on here. So this is a non-con.
Okay. And same with the
What's this?
Right. It's a T2.
Yeah, exactly. So 40-year-old guy with these like chronic positional headaches, and tell me what's abnormal on here. On here and on like this image.
What is this dura?
So I mean, start with the axial one. I don't know, it's really small, but it looks like there's some enhancement. No, what that is.
Is it the venous sinuses?
Yeah, the
Start
middle
off
one
with
looks like.
start off with this one. Like what do you see along the brain convexities?
Sorry, I thought I saw your cursor somewhere else. So the coronal looks like you see like a pachymeningeal enhancement.
Yep, diffusely. Okay, and how about this image over here? What do you see?
I mean, it looks like maybe there's some enhancement of the sagittal sinus and the straight sinus as well.
On this one?
The middle one?
Ignore that. Ignore this like thing over here. Like but look at the tonsils down here and like the subarachnoid space. What do you think?
There is some distension, like downward displacement of the cerebellar tonsils.
Yeah, they're kind of sagging and there's not much CSF, kind of like in front of the pons. The suprasellar cistern's kind of like it's kind of narrow as well. And how about the last image? What do you think of the ventricles?
They're small.
Yeah, they're kind of small. What do you see if you look in front of the brain, like in front of the brain convexities on both sides?
Oh, it's like shrinking. It's like you see space here.
So there's these like collections that are kind of bilateral and crossing sutures. So what space is that? Like crossing sutures.
Subdural.
Yeah, exactly. So diffuse pachymeningeal enhancement, narrow subarachnoid spaces, low-lying tonsils, and these like kind of like subdural fluid collections. This is, what do you think this is in the guy with chronic headaches? Which we just talked about it.
I can't put it looks like there's a KRI1.
Okay.
Because of the low-lying tonsils, but also like there's maybe like chronic subdural hematomas. I don't know.
This is actually an example of intracranial hypotension. So like the diffuse leptomeningeal enhancement, like diffuse pachymeningeal enhancement that everyone could see. When you have like say like a CSF leak from trauma and you have like rhinorrhea or otorrhea, or if you do an LP and you have like a leak like after inserting the needle, what will happen is like the amount of intracranial CSF will go down, and what you might see is narrow ventricles, and then like sagging tonsils, and then like a paucity of CSF within the subarachnoid spaces in the basilar cistern. So that's what you're seeing over here. In some patients, when you have less CSF, they might get subdural hygromas or hematomas, but like what you're seeing on here, these are probably hygromas. So this constellation of findings in the right clinical scenario is actually a good appearance for intracranial hypotension, in this case from a CSF leak. I agree this is low lying, but I'm not trying to show a Chiari over here. I'm trying to show you kind of a different constellation. The dural enhancement is kind of more is kind of like it's not what you would see if you have just a run-of-the-mill Chiari malformation. And the way this is kind of like narrowed over here, the subarachnoid spaces, I'm trying to show you that this is from like a paucity of CSF from a leak and not just a Chiari malformation. Intracranial hypertension, like IAH, can look similar to this, where you have like everything's a face and tight ventricles. But in those patients, you would not expect to see dural-based enhancement, and you'd maybe see a partially empty cella and papilledema. So that's leptomeningeal enhancement and dural-based enhancement with a differential for each. Now I'm going to move on to talking about collections. Let's see, is Wonu there?
It's here.
Yes.
Okay, so take a look at this case and just read the question. There's 3 sequences, and tell me what you think is going on.
Okay. So let's see. What is the most likely consideration in this patient with fever and known infection?
I mean, without looking at the answers, you can kind of guess what the, without looking at the images, you can kind of guess from the stem of the question what the answer is. But look at these images, like tell me what they are, the sequences, and it's like a puzzle. It'll tell you what the answer is if you look at these.
So this is, I guess you do see a leptomeningeal enhancement here in the first image.
Mm-hmm.
And you kind of see some collection posteriorly as well as kind of anteriorly.
Okay.
In the DWI sequence in the middle, looks like it. It kind of looks like it's restricting as well.
Sure.
And then in the T2 here, the last image, you kind of see the same collection.
Yep. It's actually a gradient echo. The last image is a gradient echo. What is gradient echo like mainly used for? Besides calcium, something else shows up as dark on there?
When you're looking for blood.
Exactly right. So you have a couple choices of here. 3 of them are hematoma. Is this dark on GRE, these like collections, or no?
It is.
I'm sorry, can you say that again?
So you have a few different choices here. The first 3 are like different types of hematomas. Are these collections, do they have susceptibility inside of them, or they're not dark on GRE?
No, they're not.
Right.
So I don't think it's blood.
So yeah, so A, B, and C are going to be wrong. So now you're down to these 2 last choices. Is this an empyema or just like a subdural effusion, which is typically a sterile collection? So if they restrict, is that more likely to be pus or something sterile?
I would say it's pus.
Exactly right. So I mean, there's a differential. MRI is like a puzzle. The different sequences tell you different things. For diffusions, obviously strokes are going to be are going to restrict, but other things will also restrict on diffusion. So pus is a really important thing to know that restricts on diffusion. I've seen an abscess or 2 on like prior right exams that you guys have taken, but they're usually parenchymal when they show it to you. Just know that if you see like a rim enhancing lesion that has restricted diffusion in the center of it, I would really consider an abscess if you have that, if you come across that finding on a test. So the first image shows kind of like these rim enhancing collections that are like a subdural, maybe epidural back here. There's leptomeningeal enhancement, they restrict, and there's no blood product. So these are empyemas. If they did not restrict and they were not really bright on flare, then I would think of effusions, which you could see with any meningitis, but they say it's more common when you have H. flu meningitis. So empyemas, they can be subdural or epidural, and it's the same as if you have like a hematoma in terms of like the localization of where it is in the subdural or epidural space. If it's crossing sutures but not crossing the midline, if it's going along dural reflections, that would be a subdural empyema. If it can cross the midline but stops at sutures, that would be an epidural empyema. Causes for these are going to include meningitis, if you have sinusitis or mastocytitis, or if you have direct trauma or after surgery. So this is an example of like subdural empyema. It kind of like is really broad, crosses sutures but doesn't cross the midline. Another subdural empyema in this case kind of crosses. It's kind of really broad, and it's like in its orientation, it's going all the way front to back. If you look at this case over here, there's a fluid collection. It crosses the midline but doesn't really cross the coronal suture. So this is an epidural empyema. Things that you're going to look for are going to be rim enhancement. It'll be bright on flare. It's not going to suppress because it contains complex fluid. And if you do diffusion, they're typically going to restrict. Subdural empyemas, for whatever reason, have a higher incidence or in a greater number of cases, subdural empyemas will strongly restrict. It's a variable with epidural empyemas. I don't know the exact reason why, but apparently, like in the literature, subdural empyemas are more likely to restrict than epidurals do. So we talked about dural and leptomeningeal enhancement. We talked about extraaxial fluid collections that are empyemas. Now we're going to talk about something parenchymal. So let's see, who can I call on? The number of people logging in is increasing. Lisa Calvo.
Hello.
Hey, so take a look at this and tell me what you see.
Okay. Let me. On the first, so I see a collection on the first slide on the T1. There's an enhancing collection of some hypodense material.
Okay, so density is for like CT. For MRI,
Right,
you're talking about
intensity.
intensity,
Mhm.
exactly.
Mhm.
So you're talking about this image here.
Mhm.
Okay, how do you describe the enhancement? Is it solid or something else?
Looks.
It's rim enhancing.
Like,
it's rim enhancing.
oh, that's like, okay.
Okay, so there's an area of rim enhancement, kind of like the left temporal region. What's surrounding it on the T2?
Looks like edema.
Right. Vasogenic or cytotoxic? It's in white matter, pretty much.
A cytotoxic edema.
Vasogenic. Cytotoxic is what you'd look for in a stroke. Vasogenic is more for like a space occupying lesion. So there's a rim enhancing collection that you're seeing on here, a rim enhancing lesion with a ton of vasogenic edema in the left temporal lobe. This is diffusion. What do you think of the diffusion if you look at the diffusion in the ADC?
So we're comparing restriction.
Yeah, exactly. It's bright on DWI, dark on ADC, so this is actually restricting. And this is gradient echo, which what's that good for again?
For blood.
Exactly. Do you see the center of this strongly having susceptibility, or it's not really doing that?
Not susceptible to that.
Okay. So if this is not showing like, susceptibility, is it going to be hemorrhage?
No.
Right. Okay. Do you think this is an acute infarct if it's mainly showing vasogenic edema and like kind of like rim enhancement or no?
No.
Right.
It looks like an abscess.
Exactly right. So again, it's like a puzzle. I mean, like looking at just like fever and that, you can kind of guess what the answer is, but like think of it like a puzzle.
Right.
I'm pretty sure they've shown like at least one like brain abscess of restricted diffusion on a recent writing exam that you guys have taken. Okay. So let's just go through some of the wrong answers. So typically when you have an infarct, if it's large, it'll give you more gyriform enhancement than like peripheral enhancement like this. That's like what you see. And you don't see that on like the first, on like the first day or even like hyperacute stage. Enhancement within an infarct is something you see starting around the second day. It peaks around 2 weeks and then it goes away around like 2 months. And again, like it's typically not going to be a rim. It's going to be more kind of like cortical or gyriform like this. Hemorrhage, like subacute hematomas will form a capsule and they can have rim enhancement too. But if you have hemorrhage, I'd expect to see gradient susceptibility on SWI or on a GRE sequence. So the best answer here is going to be brain abscess. So there's a mnemonic that people talk about for like rim enhancing brain lesions. Do you know what that is, Lisa?
No.
Okay. It's called Magical Doctor. So the M is for Mets, A is for abscess, G is for glioma, specifically GBM. Subacute infarcts, if they're deep and not cortical, can sometimes rim enhance. Contusions, like we just showed, can form a capsule and can rim enhance. If you have AIDS, toxo, an abscess from toxo or lymphoma can both rim enhance. And then lastly, MS can have enhancement too, or any kind of demyelination. And if you have a treated brain lesion, radiation necrosis can give you rim enhancement. So just to kind of go through these for rim enhancing lesions. So METs, abscesses, and GBMs, all these guys can have rim enhancement they can look identical. So there's other tools you can kind of use to kind of separate out what's what. They say that if you have an abscess, there's thicker enhancement along the cortical side, but in reality, I don't know how clinically useful that is in real life. And they talk about it in books, in review books and textbooks, about the outer edge of a abscess being thicker than the kind of like deeper edge over here, because there's more blood flow on the outside. In clinical practice, I feel like mets and other stuff can also have a thicker edge, so that's not the most useful thing in reality. So what are some like tools you can use to kind of separate these out? Like, I mean, if you do MR perfusion, tumor is often going to have higher cerebral blood volume compared to like an abscess. And there's also different spectroscopy things that you could do to look for an abscess, like amino acids. I'll show that in a couple slides later. We just talked about this. If you have an infarct that's kind of like lacunar or kind of deep over here, in theory, that can have rim enhancement when it becomes subacute. Most infarcts are typically going to be cortical and gyriform when they're large like this. Hematoma, like I said, look at the gradient echo or susceptibility weighted image, just look for a dark signal. And if they have a head CT, look for obviously high density to go along with hemorrhage being the cause of a rim enhancing lesion. Lisa, what do you see on here? So this is actually demyelination, like Dawson's fingers, rim enhancing lesions, stuff within the corpus callosum, especially the undersurface. What's special about this rim enhancement that you see on here that's typical for demyelination?
It's not, doesn't like surround the entire area.
It's
Doesn't go to
incomplete.
the
Yeah,
cortex.
it's incomplete. That's the specific thing you're looking for here. Like if you have an incomplete ring, that's something you'll see more commonly with demyelination than say like an abscess or a tumor. So I'm just going to talk for like 1 or 2 slides about the progression of like how you get like a brain abscess. In terms of like causes of these things, I mean, like hematogenous spread is going to be a major thing to think about, especially if the person has a shunt, like if they have like an AVM somewhere, or if they have like a cardiac shunt. If they're an IV drug abuser and they have endocarditis, or if they have some other systemic infection. You can also get them from local extension of sinusitis and mastocytitis, and also from surgery or direct trauma. A big thing to think about though is if you see these, worry about something cardiac like endocarditis, maybe if they're an IV drug abuser, if they have a shunt or like an AVM. So in terms of the progression of these things, like early on, cerebritis is like the first stage of like the development of a brain abscess, where you might see some patchy bright signal on flare, maybe some minimal enhancement, maybe some restricted diffusion, but not a circular walled off rim enhancing fluid collection. It's localized but not well organized yet, and you won't see rim enhancement. If you wait like a few days, like maybe a week or so, then you'll start to see more of like a capsule forming around the lesion with rim enhancement. And if you wait like a little bit more than that, then you'll see kind of a mature, well-defined lesion that has like really thick rim enhancement around it. In terms of complications of abscesses, classically, again, the outside of an abscess is going to be thicker because there's more blood flow towards the cortex. The inside's thinner, so that predisposes these to causing ventricular complications and interventricular rupture. So you can get ventriculitis, choroid plexitis, and you can have where it frankly ruptures into the ventricle. And when that happens, that's typically a pre-terminal event. People that have interventricular rupture of an abscess don't live for more than 1 or 2 days afterwards, typically. So I just showed you like that broad differential for rim enhancing lesions, magical doctor. So what tools can you use on MR to help you figure out if like the rim enhancing lesion is actually an abscess, not like a tumor? Typically, if something has very strong restricted diffusion, that's probably going to be an abscess or maybe an infarct. The other things that cause restricted diffusion, like sorry, let me backtrack. I think I spoke too fast. If you have restricted diffusion, the things that cause the strongest restricted diffusion are going to be infarcts and abscesses. Tumors and demyelination and things like that are typically not going to have as strong restricted diffusion. If you look at the wall of an abscess, it's classically going to be dark on T2 and kind of bright on T1 from deposition of free radicals. That's something you won't see as commonly if you have like a MET or like a GBM. So strong restricted diffusion is one big clue that it's an abscess and not a tumor. Bright T1 signal and dark T2 signal surrounding like the rim of the lesion. And if you do MR spectroscopy, I mean, necrotic tumor and abscesses can both have high lactate. If you see amino acids elevated, that's a clue that you're dealing with an abscess, a pyogenic abscess, and not a tumor. Lastly, like we talked about, perfusion can also help you. Tumors are going to have higher cerebral blood volume, and abscesses are going to have less high cerebral blood volume. Map block.
Hello.
Hey, okay. So take a look at this case and tell me what you think.
Okay, I'm looking at a series of axial images on the T1 post. I see several things. I see one small rim enhancing lesion, several confluent enhancing lesions, and one that has strong ring enhancement and more moderate central enhancement.
Right.
And
So
then it looks like maybe this is the same patient over time because it's still another T1 post. And then finally on the flare, I see significant temporal edema, which appears to be vasogenic.
right. It's looking into the white matter. Good.
Yeah.
Okay.
Knowing, and then I see a lung with an abscess, or excuse me, with fluid, and I guess I'd call those cavitations.
Right.
So his HIV puts him at high risk for everything. Those CD4 is not actually that impressive, and his sputum is positive for AFB. So in terms of what this could be, so Cryptococcus can give you the similar lung lesions that TB can, and I think can also give you these enhancing lesions. It wouldn't explain the positive acid fast unless that is a red herring.
Yeah. So I'm not trying to trick you.
Oh, okay. Lymphoma, again, he's at increased risk for this because he has HIV, but I've never seen like a bunch of kind of discrete ring enhancing lymphoma lesions. TV can give you everything here.
Right.
And toxo, again, I think the issue here is the lung findings and the acid fast. So my best answer would be TB.
Right. I mean, I gave the CD4 count to kind of steer you away from opportunistic infections. Lymphoma, if you have AIDS, can give you a rim enhancing lesion. It's actually more common if you're immunocompromised for lymphoma to rim enhance than to solidly enhance. They say that classically lymphoma, if you have AIDS, is more likely to be solitary than multiple. Toxo, classically is going to be multiple, kind of multiple enhancing lesions. But like in this case, there's a cavitary lung lesion with an air fluid level. I told you they're AFB positive. Their CD4 count is not really, it's not below 200 or so. So for this case, I think the best answer is going to be that this is actually TB, which is like the next topic I'm going to talk about. This is obviously the organism that causes TB. You typically get CNS involvement in tuberculosis from pulmonary or GI infection less commonly. I mean, like when it first involves your brain, it kind of goes over the surface and like forms these pockets, which are called rich foci. I mean, you guys would probably know this better than me about like diagnosis. I guess you could do like AFB, or you can do maybe like a PCR test, like from the CSF, to kind of diagnose this. So for CNS involvement of TB, it can do different things to your brain. The way I think about it is like in broad categories, it typically does three things to your brain. So you can get TB meningitis, which classically is going to be a basal meningitis, like granulomatous diseases like sarcoid and TB, like to involve the basal cisterns and like the undersurface of your brain. It can cause dural base or leptomeningeal enhancement, like you're seeing in this case. So meningitis, which they say classically likes to involve the basilar cisterns and likes to give you thickening of the infundibulum. Another way that it appears that I'll show you in the next couple slides is going to be tuberculomas. And then lastly, you can get abscesses with these. So these are examples of just TB meningitis. Again, granulomatous disease, including sarcoid and TB, like to involve the basal cisterns and can give you thick enhancement. The circle of Willis lives around here. So in several of the cases of TB meningitis I've seen in the past few years, they often get infarcts because it likes to involve the base of the brain. It encases these vessels and can cause infarcts. Right. So tuberculomas are going to be when you have like rim enhancing lesions from TB, and they're classically multiple, like you're seeing in this case. Like TB abscesses are more often going to be solitary, or maybe one or two. If you see many rim enhancing lesions in a patient with known tuberculosis, those are more likely to be tuberculomas. They will rim enhance like an abscess. They can often restrict like an abscess. But one differentiating feature is if you look at the T2 signal of tuberculomas, they're often going to be intermediate or dark. So if they're multiple, and if they have like intermediate or dark T2 signal, I think I would favor tuberculomas over TB abscesses. So tuberculous abscesses can look exactly like a pyogenic abscess. They can be solitary, or you might have daughter abscesses right next to it. They rim enhance, they will restrict. One thing that is in the literature, though, is that when you have a tuberculous abscess compared to a pyogenic abscess, pyogenic abscesses will often have the amino acids that we talked about on spectroscopy. Tuberculous abscesses will have high lactate, but not really the high amino acids. Matt Block, since we're talking about this topic, there's three broad categories of things that can give you infundibular thickening. So one of them is going to be granulomatous disease, like sarcoid and TB. Can you give me two other causes for broad categories?
Okay. Well, my broad categories would be malignancy,
Sure,
and infection.
Okay. So for infundibular thickening, so granulomatous diseases like infection from TB, like sarcoid. Let's say I told you it was a child that had lytic lesions in their skull and diabetes insipidus. What would you think of for that as a granulomatous disease that can give you infundibular thickening?
I'd be thinking that. I'm not sure.
So LCH, eosinophilic granulomatosis, or Langerhans cell histiocytosis, can cause diabetes insipidus and give you a suprasellar lesion. Classically, it'll be like infundibular thickening that you might see with that. So those are three kind of like big granulomatous diseases that can give you infundibular thickening. Tumor, like you said, can also give you infundibular thickening. So if you have Mets with leptomeningeal involvement, that can give you infundibular thickening. If you have like lymphoma, I've seen that also cause infundibular thickening and other lesions as well. What tumor, especially with the younger patient, that happens more commonly in the pineal region, can also involve the suprasellar region? Begins with a G.
Glioblastoma?
Germinoma. Germinoma likes to go to like the infundibulum, actually. It's most common intracranially in the pineal region, and the number 2 location would be kind of suprasellar by the infundibulum. Lastly, so granulomatous disease, different tumors are like another category, and like a third category. Let's say I told you they were recently pregnant or kind of late stage pregnancy, and they have infundibular thickening. What entity that happens in that kind of category of people, like pregnant or recently pregnant, like females, can give you infundibular thickening?
Apoplexy?
No. Apoplex is a pituitary thing, not an infundibulum. So lymphocytic hypophysitis is like a thing that you have to know about that causes infundibular thickening, specifically in pregnant females or recently postpartum, and it's IgG4 mediated. So these are kind of the broad categories of a few things things that can give you infundibular thickening. So I just kind of talked about bacterial stuff to death in terms of leptomeningeal and like dural base enhancement, abscesses, empyemas. We talked about TB. Now I'm going to switch gears and talk about something else. Murray, are you there?
I'm here.
Okay. So take a look at this case. It's kind of like a trick question, but like look at the history. That's the most important part, and tell me what you see on the CT.
Sure. So fever, headache, right-sided weakness, In the axial CTs, there's
You definitely had this on your right exam, like at least like I remember seeing like a flare image and that kind of thing showing the same entity. So this is definitely worth remembering in real life and for your test.
okay. So there's the first one is left temporal hypodensity, and then you see that on the second one, and maybe frontal as well on the third. And then there's also a linear hyperdensity
Right.
within that.
Okay.
Um,
And what is this out here that's hypodense? This structure over here.
oh, that's, I guess is that the outside of the, no, it's basically payment.
It's just the insula. So
Oh, the insula.
left temporal, kind of like anterior medial, and like over here, kind of like more posteriorly behind the temporal horn. Maybe the basal frontal, and also the insula over here. So what do you think this could be?
Could this be herpes encephalitis?
Yeah, exactly. Most people, when they see this, they shoot from the hip and they say acute MCA territory infarct for the dense vessel. But take a look at this on here. If you look at this MRI, there's bright signal kind of in like the basal frontal lobe and medial over here. There's bright signal kind of diffusely involved in the anterior temporal lobe, lateral, anterior, medial, and kind of like back here posteriorly. The insula is involved. And if you look at this gradient echo image or SWI that you're seeing here, there's some like blood products and it's restricting. Just 1 second, actually, someone's knocking on my door. Sure. Okay. Thanks. Murray, you still there?
Yes, still here.
Okay. So you're correct. This is actually herpes encephalitis. So like there's a couple of things on here that'll help you differentiate this from like a stroke. So let me ask you this: like, is this one vascular territory or multiple vascular territories?
This is, I mean,
Like,
it's all MCA.
this is MCA over here. What territory is this?
It's ACA.
Yeah, and like what territory is like this back here?
PCA.
Yeah, and what territory is like the uncus or the amygdala over here?
That's going to be the interior. No, that's
Yeah. That's
right?
anterior carotid artery. So if you look at this, there's actually multiple territories involved. Unless you have like a fetal PCA or something like that and a distal ICA occlusion, this doesn't really fit well for an infarct. And on top of that, they have a fever. So this is kind of a classic example of like a herpes encephalitis involving the temporal lobe, the basal frontal lobe, the insula without involving the basal ganglia with a little bit of hemorrhage. So just some background information about this, which again, you guys probably know more about the clinical stuff. You guys definitely know more clinical stuff than I do, obviously. But for herpes encephalitis, it's most commonly going to be caused by HSV1. You get it from spread of like the reactivation of the HIV. The HSV of HSV that's from the that's within the trigeminal ganglion. It's a medical emergency. You want to really like identify this and not accidentally call this a stroke if you see it on like a head CT, because if you don't start treatment, obviously they do pretty poorly. And just kind of showing you like the way this evolves. If it starts off in like the trigeminal ganglion, Meckel's cave over here, that's kind of how it spreads to the temporal lobe, the basal frontal lobe, and the insula. Let's see. Okay, so in terms of imaging, again, think about this if you see diffuse temporal lobe involvement that doesn't fit one vascular territory. If you see a large abnormality that fits a vascular territory, that's probably going to be a stroke. If it doesn't fit a vascular territory, then you got to think about maybe something inflammatory or a space-occupying lesion. It classically goes to the insula, but doesn't involve the basal ganglia. It classically is going to have a component of hemorrhage associated with it that can bloom on gradient echo. And while it very commonly starts off unilateral, a lot of the time it'll become bilateral, like you're seeing over here. And what other diseases can give you medial temporal lobe edema? So Murray, take a look at this case. Look at the stem over here and tell me what else can give you give me something. Answer this question. Tell me what's in the differential for medial temporal lobe edema.
So if based on this stem, I would say probably you're looking at a paraneoplastic encephalitis.
Exactly. Like limbic encephalitis, which can be autoimmune or paraneoplastic, can also give you temporal lipedema. So just think about that. Let's say you have a patient that has a good, I guess, MR imaging appearance for herpes, but their titers are negative. I would think about, do they have autoimmune encephalitis that's non-infectious, or do they have paraneoplastic syndrome, maybe from lung cancer or a GYN issue? And what do you expect to find in the CSF or maybe the serum in this patient, Murray?
Oh,
I don't know what they are exactly. I know the broad category, but I don't know the individual ones.
yeah, there's like you or who.
Yeah, just autoantibodies. Again, you guys know this better than me, but just be aware of that. Okay. Just gonna keep going then. So we're talking about viruses. Like herpes is a big one you don't want to miss clinically, and then obviously they show that on the right exam before. So West Nile is a type of flavivirus. So West Nile and other flaviviruses, like when they involve your brain, they can do different things, but classically they like to involve deep gray structures like your basal ganglia and thalami, like you're seeing in this case. COVID obviously was a huge thing last year and it's resurging now. It can involve your body in different ways. You can get a pulmonary infection from it. It is said to cause hypercoagulability and can give you pulmonary embolisms, DVT, MIs, and also CVAs. And it can also go to your brain and give you meningeal encephalitis as well. So this is a case report that was published when COVID kind of first really surged in New York around like March out of Detroit, just showing you involvement of like the temporal lobes, the deep gray structures over here with the hemorrhagic component on a gradient echo. So we talked about like different patterns of enhancement, leptomeningeal, pachymeningeal, rim enhancement. We talked about abscesses and the development of them. We talked about different encephalitides, like herpes is a big one that you have to know. Flaviviruses like West Nile like to go to deep gray structures. We talked about how COVID can go to your brain and give you a meningeal encephalitis. I only have a couple minutes left. Actually, I'm past time right now. Should I stop right now? You guys are busy doing clinical stuff. Do you want me to just stop or do you want me to go for a couple more minutes?
A couple more minutes.
Okay. So I'm going to finish up by talking about, I guess, like HIV. Srinath?
Yes, Dr. Velaydun.
Hey. So we're talking about HIV and opportunistic infections. So take a look at this case. And then take a look at the images I have over here. These are two flare images, and this is a T1 post. Describe what you see on here and tell me what you think the best answer is.
So there's bilateral flare hyperintensities around the ventricles.
Yep.
And they don't seem to enhance with contrast.
Nope. Okay.
And so I would probably think of HIV encephalopathy.
Yeah.
I think PML is usually like more confluent and larger hyperintensities.
Right. So PML, I'll get into this, but the distribution, it argues against PML for this case. So starting from like the top down for like the wrong answers, lymphoma is typically going to give you an enhancing lesion when you get it. Solidly enhancing more commonly if they're immunocompetent. If they're immunosuppressed, they're more likely to be rim enhancing lesions. It's densely cellular, so it'll be often hyperdense on CT, and it'll often restrict like other densely cellular tumors do. So this is an immunocompromised HIV positive patient that has more of a rim enhancing pattern of their lymphoma. And this is just restricted diffusion. So different densely cellular tumors like lymphoma, like meningiomas, and even medulloblastomas can restrict. Just be aware of that. What are some tools that can kind of help you figure out that it's lymphoma or a tumor rather than the other entities here? If you do a PET scan or if you do a thallium scan, lymphoma is going to be avid on those studies, but like the infection is going to be less likely to be bright on those. PML, like you're saying, is more likely to be confluent, but more specifically, it likes to involve the subcortical U fibers that are kind of out here. It causes like a type of demyelination, so because of that, it can often involve the corpus callosum, and the same way MS can go to the posterior fossa, 25% of PML can go to the posterior fossa as well. The main reason why this is not PML is it's symmetric and it's mainly deep and periventricular. In this case, this is mainly involving kind of like peripheral U fibers and also corpus callosum. That's a better look for PML than HIV encephalopathy. Toxo classically gives you multiple rim enhancing lesions. There's no rim enhancing lesions here, so the best answer for this case is actually going to be HIV encephalopathy. So this is due to direct infection of your microglia by the HIV, by the virus itself, and it's supposed to be dependent on like your CD4 count and if you've gotten treatment or not. If your CD4 count is obviously lower, you have a higher viral load, you're more likely to have this or have progression of this, and it sometimes actually gets better when you treat the patient. So this is the prior example, just showing what you'll see typically on imaging. So abnormal signal on flare with no enhancement, that's more likely to be symmetric, periventricular, and deep. It almost looks sort of like really bad small vessel disease. No mass effect, and again, no enhancement. Congenital HIV is something I would think about if I saw a child that has basal ganglia calcifications. So your basal ganglia typically are not going to calcify until, let's say, the late 20s or 30s. If you see symmetric basal ganglia calcifications in a child, one thing I would think about would be congenital HIV infection. Let's see.
Dr. Ben?
Yes.
Can I have a question? So how can we say apart the HIV encephalopathy and the other one, the microvascular ischemia?
I think it's just by history. I mean, sometimes they can look pretty similar. If you have a like, it's common over here to have people that are older, let's say 70 or 80s, that have kind of vascular risk factors and HIV. They can look very similar on, so it's really hard to tell the difference. If I see, you know what, like if I see atrophy with central volume loss, like big ventricles, and then on the background I see that bright signal around the ventricles and they have a low CD4 count, that would favor that the patient has HIV encephalopathy as a cause for those changes than just run-of-the-mill small vessel disease. But there's a lot of overlap with those two entities. So central volume loss of big ventricles would make me think more of like HIV encephalopathy than just small vessel disease, but there's overlap. Let's see, Srinath, you still there?
Thank you.
Yes.
Okay. Can you tell me what metabolic disease that, or what disease that begins with an F that you see more commonly in adults that's going to give you basal ganglia and cerebellar calcifications?
Farce disease.
Yeah, exactly. Just since we're showing like a slide of that, a young patient, a child with basal ganglia calcifications, one thing to think about might be a metabolic problem, congenital HIV. If it's an older patient, Farce disease is something that you should think about, especially on a test. Let's see. Fatma?
Yes.
Okay. So another patient with HIV. We just talked about HIV encephalopathy. Take a look at this case. This is proton density. It's like what we had before flare, but it's very similar in the way it appears. So imagine this is like a flare sequence, and this is the T1 post. So I actually just gave you the answer, but so what do you think is the best answer based on these choices? Like, so HIV, very low CD4 count. The proton density shows bright signal that's mainly subcortical going to the corpus callosum, not symmetric looking, and there's not really any enhancement on the T1 post. So what do you think this is?
So I think obviously it's not HSV.
Right.
I'm not sure, but I think it can be JC virus.
Right. So if it was symmetric and periventricular, then I would think of HIV encephalopathy. If it's really asymmetric, involving subcortical U fibers and also may go into the corpus callosum, then I would think more of like a PML, which is caused by the JC virus. CMV, I'll talk about a little bit later. It gives you other kind of classic findings in the brain, namely ventriculitis. PML is caused by the JC or John Cunningham virus. It's something you could do a PCR for in the CSF to kind of like look for this. It's something you'll see in people that have a lower CD4 count, obviously. If you don't treat the patient, it has a pretty poor prognosis. And classic things that you're going to be looking for are going to be peripheral kind of subcortical white matter involvement involving U fibers, and it can also go to the corpus callosum and the posterior fossa. So these are just different examples of the same thing. This is our case kind of showing subcortical U fiber involvement. This is another case kind of confluent involving subcortical U fibers and also going to the corpus callosum. It either has no enhancement or very similar to like demyelination, because it is a type of demyelination. It can have some edge enhancement like you're seeing in this case. It's often incomplete. Kind of more examples of the same thing. Just showing you that it involves subcortical U fibers. Let's see. So just to differentiate again, HIV encephalopathy, I'd look for symmetric, deep and paraventricular white matter abnormal signal. I'd look for maybe evidence of central volume loss with big ventricles. And for PML, it's more likely to be asymmetric, more peripheral. It can go into the corpus callosum. Like other things that cause demyelination, you can go to the posterior fossa too. One thing they talk about is that demyelination, including PML, very often has like dark signal on T1, like black holes. That's less common with HIV encephalopathy. HIV encephalopathy won't enhance. PML will have either no or maybe edge enhancement. Fatima, do you know what, let's say you gave the patient a heart and their CD4 count was rapidly rising and suddenly their lesions in their brain all started to kind of enhance and restrict and have mass effect. Do you know what entity does that?
I'm not sure actually.
Okay, anybody know? So iris, if you have a patient with a low CD4 count and you give them heart therapy and their CD4 count rises and they're doing better, paradoxically, they can get an immune response that can cause worsening of like their pre-existing lesions. Let's see. Yeah, it's like almost 1:15. I think I'm going to stop now. I have another lecture on, I think like not next week, but the week after that. I'll try to put some like write exam slides in there. If you have any questions, my number is 5103, or you can email me.
Thank you.
Yep.
Thank you.
Thank you, Dr. Zin.